Today I'd like to talk briefly about myotonic dystrophy type 1 and 2. I'm going to give you a very brief overview of the endocrine system. I'll mention those endocrine issues that I think are most likely in patients with myotonic dystrophy, and it'll be heavily focused towards myotonic dystrophy type 1, largely because of the relative newness of myotonic dystrophy type 2 and the relative lack of detailed studies of the endocrine issues in either of the two forms of myotonic dystrophy. So I'm going to talk at some length about insulin resistance. I'm going to ask you to bear with me because some of what I'm going to cover is detailed and deals with molecular mechanisms. Talk a little bit about diminished growth hormone release, about the challenge of treating patients with hypothyroidism, what's the impact of low testosterone, which is fairly common in myotonic dystrophy, particularly myotonic dystrophy type 1, complications of pregnancy in myotonic dystrophy type 1, and then close by raising some questions and talking about opportunities for future research, and then open up for questions and discussion. And so let me start first by giving a very quick overview of myotonic dystrophy type 1 and 2 in the next two slides. We'll start with myotonic dystrophy type 1. It's certainly a disease of varying severity and onset. It can start in infancy and childhood, maybe 10% of cases, and later in adulthood. Its primary features are distal weakness and wasting, although some patients don't have that for many years. Facial weakness, as you see in the photograph of the father and son on the right-hand side of this slide, and then myotonia typically showing up in grip, but sometimes in the tongue and sometimes in the jaw and other places with delayed muscle relaxation after activation. The issues involved in the endocrine system are sort of highlighted by the lower portion of this slide, which talks about multi-system involvement that occurs both in myotonic dystrophy type 1 and type 2, and includes the brain, eyes, particularly cataracts, alterations with respiratory function, particularly the regulation of breathing and sleeping, and the heart, conduction disturbances in particular, gastrointestinal system, and as some of you know, there's a problem with excessive daytime sleepiness, and then the endocrine system. For myotonic dystrophy type 2, emphasized again by this father and son series of photographs that we took from patients in Germany near Würzburg. This is a disease that also has varying severity, begins in early or late adulthood. There are multi-system complications similar but not necessarily identical to myotonic dystrophy type 1. There's a somewhat lower propensity of serious cardiac conduction disturbances and a lower propensity for respiratory insufficiency. There are other distinctions compared to patients with myotonic dystrophy type 1. Patients with myotonic dystrophy type 2 often have a later onset of symptoms. They have a peculiar troubling type of muscle pain that seems somewhat different from the pain that myotonic dystrophy type 1 patients suffer with. They have more proximal shoulder and hip girdle weakness and neck flexor weakness early in the disease compared to myotonic dystrophy type 1. And then one major difference is there does not appear to be a congenital form of myotonic dystrophy type 2. But as Professor Peter Harper has emphasized, there's a broad range of manifestations in myotonic dystrophy, and he has emphasized that it's probably the most variable disorder known in medicine. And one of the reasons for this may very well be the involvement of the endocrine system, which touches so many different organs and so many different functions in the body. So if we take an overview of the endocrine system and ask ourselves, what does it involve and what systems might it impact? It's a collection, as you know, of glands that produce hormones that regulate many functions in the body, including metabolism, energy levels, growth and sexual development, different aspects of sleep and mood, all kinds of homeostatic regulatory mechanisms involving internal balance, sometimes involving clock systems, menses, for example, bone and muscle strength, and reproduction. And this slide emphasizes the anatomy and location of the different glands in the endocrine system. And as you recall, historically, it was the testes, which are listed at the bottom of this slide, and decreased testicular size and function. That was one of the first things that was identified as an endocrine alteration back in the very early 1900s when the disease of myotonic dystrophy type 1 was first described. So what are hormones? Hormones are chemical messengers. Sometimes they're little teeny pieces of protein, so-called peptides. Sometimes there are other molecules that travel in your bloodstream to target tissues or organs that are in touch and regulation with these chemical messengers, and very often through things called receptors. These hormones are powerful, as many of you know who've had to deal with some type of hormonal problem. Just a tiny change in the level of a hormone can sometimes make a big change in how your cells are activated and how that influences whole body behavior and metabolism. And if they're out of whack or deranged, that can cause health problems. There are a variety of laboratory tests that are helpful to perform, and some are in the blood, some in the urine, some in the saliva. And if you go to this website, it's often helpful to look at their recommendations. Now, what I've decided to do for this afternoon is select certain endocrine issues that affect the management of patients with myotonic dystrophy, and very briefly highlight approaches to the care of those issues. And I will give you sort of an advance warning that I'm going to spend a lot of time talking about insulin resistance, mainly because we know a little bit more about the probable mechanism that underlies the insulin resistance in myotonic dystrophy, and some of the manifestations of insulin resistance can, in fact, lead to medical problems that require treatment other than what you might ascribe typically to the management of something like diabetes, which once you hear the term insulin resistance, you immediately think, uh-oh, maybe I have diabetes. But as I'll try to emphasize in these brief remarks, insulin resistance can affect body metabolism without causing frank glucose intolerance and typical diabetes. If anything, it can look a little bit more like prediabetes, or even to some extent the metabolic syndrome, although the vast majority of patients with myotonic dystrophy do not have hypertension and some of the other features of classical metabolic syndrome. Now, normally the functions of insulin are regulated in the following way. The pancreas manufactures the hormone insulin, this very small protein, this peptide, which it releases from the beta cell in the pancreas, and it travels through the bloodstream to help glucose, the primary sugar of the body, enter a variety of its target tissues. And typical examples are muscle and fat, and of course the brain and others. But insulin regulates primarily muscle and fat, and to some real extent the liver. Now, if you look in the right-hand side of this slide, you'll see a cell, idealized cell, and then you'll see a little key that's a symbol for insulin, and then a little keyhole, which is the receptor for insulin that sits on that cell, and then in red, a schematic of a blood vessel that in it contains a mixture of insulin and glucose. And this glucose is taken up by the cell following insulin's attachment and stimulation through this receptor that's symbolized by the keyhole. If you ask yourself what it is that might interrupt normal insulin action in the body, there are two big categories. One category is that insulin may not be there in adequate amount. In other words, it's limited in supply. The other option is that the action of insulin is actually prevented and blocked by some mechanism, not necessarily the supply. And the limited supply of insulin is typically what happens in type 1 diabetes, where there's been damage to the beta cell and somehow the pancreas is unable to make adequate amounts of insulin. So you have insulin just not adequately there, sufficient quantity to open this receptor and stimulate it. On the other hand, and this is true for myotonic dystrophy as well as for type 2 diabetes, through various mechanisms, the actual receptor or ability of insulin to attach to that receptor is compromised. And because of that, the signaling through that receptor is limited, and it requires often much higher levels of insulin to accomplish the task that's needed to allow normal metabolism of glucose. Now, one of the things I'd like to have you get prepared for in the next 3 slides is dealing with some ideas about the molecular pathology of myotonic dystrophy. And bear with me, not all my slides are going to be like this, but I think it's important to talk a little bit about the exact mechanism that may underlie how this receptor on the cell in myotonic dystrophy could be manufactured incorrectly, and also to talk a little bit about the gene defect in myotonic dystrophy, the mutations in both myotonic dystrophy type 1 and myotonic dystrophy type 2, and how they actually are creating a problem with the insulin receptor and a number of other proteins that are important in cells that cause the thing called a splicopathy and RNA toxicity. So what is this that I'm talking about? It has to do with the cell biology of myotonic dystrophy. And what is part of that, the idea of RNA toxicity. The mutations in both myotonic dystrophy type 1 and type 2 cause a collection of abnormally enlarged RNA. After the DNA is read, RNA that results is abnormally expanded because of the mutation, and it changes the way the nuclei inside the muscle cells and other cells in the body behave. This particular slide emphasizes that there's some RNA regulatory proteins, and one of the principal regulatory proteins that's being embarrassed and sequestered and altered in how it acts in myotonic dystrophy, both type 1 and 2, is as the following. These nuclear regulatory proteins are sort of like a foreman on the job. Ordinarily, they're out, as shown by these little green blocks, and they are free to regulate and function and tell the cell, the nucleus, make this kind of protein, make this kind of protein. Now, they need to be out free and able to do their job. If you look at a healthy cell and wonder what this is actually a nucleus that's been stained so you can see all of this muscle blind, this regulatory protein. Below a similar type cell, a patient with myotonic dystrophy type 1. And all of the nuclear regulatory proteins have been taken out of the nucleoplasm and sequestered, sort of drawn into a little ball, and that little ball forms a ribonuclear inclusion that sort of sits there and doesn't allow these nuclear regulatory proteins to be free as they are normally to do their action. So the regulatory proteins are stuck, to this RNA, which is abnormally expanded, and it prevents them from doing their particular assignment, their role as a foreman on the job, and they're unable to read the blueprint and do the things that they're supposed to. Now, in the next two slides, things may even get a teeny bit more complicated, but at least those slides will build on what I've tried to communicate in this slide. So let's ask ourselves what happens normally when you look at the gene that's involved in the mutation in myotonic dystrophy type 1 and to the gene that's normally functioning in myotonic dystrophy type 2. Now at the top of this slide, there's a thing that says DMPK, and that's the myotonic dystrophy or dystrophia myotonica protein kinase gene. And then on the right-hand side is the comparable gene. This is on chromosome 3. This is chromosome 19. This is for myotonic dystrophy type 2. Now, there are going to be some symbols that you'll see in this slide and the next slide. One is this little green symbol, and it's this muscle-blind MBNL1, and it's the material that I mentioned in the previous slide. I didn't mention this CUGBP1, and I don't want to spend a whole lot of time talking about it, but it's another nuclear regulatory protein that is important in the cell, and that when it's phosphorylated, it may create misbehavior in the manufacturing of muscle. And it's conceivable that if it misbehaves enough, it could create muscle weakness. It doesn't do this except when it's phosphorylated. It has that little P attached. Up here is the normal way we would like to see CUGBP1, and we'd like to see muscle-blind free and able to do its regulatory function. If you want to read a little bit more about this, you can look up this article in Neurotherapeutics written by Thurman Wheeler in our laboratory working with Dr. Thornton. So this is a schematic of the normal gene containing the DMPK gene site, and there's a place down here in the so-called non-translated region where there's a CTG repeat, and as you recall, number of repeats here is usually between 5 and 30. In myotonic dystrophy type 2, there is a 4-nucleotide, a 4-component where you have CCTG repeats. It's in an intron as opposed to in the 3' untranslated region. And this is on chromosome 3q21. No reason to remember that other than that the size of this repeat is usually less than 78 of these repeats. Often it's down in the 30s. So normally what happens? In myotonic dystrophy, the gene is translated, made into RNA. That RNA forms CUG, which is the RNA equivalent of CTG. It's quickly handled in the nucleus normally and then moves out of the nucleus quickly into the cytoplasm to do all its different assignments. In myotonic dystrophy type 2, because this particular expanded piece of CCTG is in an intron, the way that works molecularly is it gets cut out and it's just disposed of. So down here in the mRNA that's manufactured, it's just sitting there without any little red mark in it whatsoever, just like this is for myotonic dystrophy type 1. Now, I know that's complicated, but let's handle this one, which may seem more complicated. At the top of this slide on the left, you have myotonic dystrophy type 1 mutation. And that is in this region, the untranslated region, where you can see it says CTG expanded. And usually patients with myotonic dystrophy type 1 have greater than 100 CTG repeats. Certainly 5 to 30 is the normal range. Once it gets much over 50, tendency for expansion occurs. And many patients have much bigger CTG repeats than 100. It could be in the congenital form as high as 2,000 or more. In myotonic dystrophy type 2, in intron 1, you see a very extended CCTG repeat. And it's way above 78, and it could be up in the range of 5 to 15,000. Now, in both myotonic dystrophy type 1 and in myotonic dystrophy type 2, these repeat expansions can form what they call hairpin loops. They can loop around, and it's this normal loop structure. The physics of this lodges it in the nucleus, like you saw a couple of slides back. And this material, this toxic RNA, lodges in the nucleus. It just sits there and starts capturing this muscle-blind 1. You remember I told you that it should act as a foreman on the job, but in order to act that way, it has to be free to act. And here it is being trapped by these abnormal hairpin loop formations that form these ribonuclear inclusions. Now, one of the other sequelae and side effects of this mutation in myotonic dystrophy type 1, if you remember I mentioned before, this little blue symbol is CUGBP1. But I mentioned that if it's phosphorylated and has a little p, that it can do mischief. And one of the problems is it can impact negatively on the manufacturing of muscle. So what happens when you form these ribonuclear inclusions in these two forms of myotonic dystrophy? In myotonic dystrophy type 1 and type 2, the muscle blind held captive by these repeat expansions. And so its function is lost. Its function is to help the nucleus decide on the proper form of certain proteins. And in the case of insulin resistance, one of the things that impacted and damaged by this splice option is the insulin receptor, that little keyhole that you saw in the previous diagram. And so it's not built correctly. It's built more in what we call the fetal form, like a little baby, as opposed to the adult form. And so it's not prepared to signal the way it should. There's also a defect in the manufacturing of a thing called the chloride channel. And we're not going to talk about that today, but the chloride channel is very important in maintaining the contraction characteristics of the muscle fiber membrane, and the chloride channel is not manufactured in the appropriate amount as an adult form, and so when that happens, the muscle can't relax as quickly as normal, and you get this contraction of myotonia muscles. And there are a number of other proteins that undergo damage from this spliceopathy. So thank you for bearing with me during these complicated slides, but I thought it would be helpful to give you a better idea about what it is from a molecular standpoint that causes the insulin resistance, and it also puts you in a little better position for thinking about new strategies for treatment. And remember, as Leslie was saying, one of the treatment protocols we're pursuing right now is the use of a thing called an antisense oligonucleotide. And on another day, probably you'll have a webinar where people will talk about antisense therapy. And one of the ideas behind antisense therapy in the current protocol is to have a mechanism that attacks that abnormally expanded RNA and removes it, so that there's no longer this sequestering and sort of preventing of muscle blind from doing its job. It's allowed to be free and to carry out its blueprint reading and manufacturing of the proper protein. So the fact is that there is a deficiency of the adult form of the insulin receptor in myotonic dystrophy. And so these receptors do not respond correctly to insulin, and there's an excessive release of insulin that has to occur in order for the cells to take up glucose in the rate that they need to and to distribute glucose appropriately to muscle and fat. So that if you look at this diagram and you look at the blue dots of glucose and the yellow dots of insulin, normally there's a certain mixture that is released of insulin by the pancreas to handle a particular dose of glucose, and then there's a nice uptake by this idealized cell and this movement along out of the blood vessel. In insulin resistance, there is much more insulin required to help even a smaller amount of glucose go into cells. So in some patients who are really insulin resistant, you'll see an elevated glucose or a prolonged elevation of glucose within the normal range. So you have too much glucose in the blood, and then some of the other side effects of insulin resistance are what's called abnormal lipid metabolism, where you have elevated cholesterol and fatty acids, and you also have a compromise in one of insulin's actions, and that is to build muscle and to help repair muscle. On top of that, insulin at even very low levels is an important regulator of potassium. And if that regulation is not working properly, it aggravates muscle stiffness and myotonia. Now, if you're going to screen a patient, and very often patients with myotonic dystrophy do, just like the rest of the population, require screening for prediabetes. That's a condition that many diabetics have before they develop frank diabetes, and very often prediabetes occurs in people who have so-called syndrome X, or have the metabolic syndrome where they're hypertensive and overweight and tend to have a tendency towards developing diabetes. That's called a pre-diabetic state. And if you look at the bottom of this slide, what you see are three different types of blood tests that are used frequently to assess whether a person is at risk of developing diabetes. One is called hemoglobin A1C, and hemoglobin in blood binds glucose through a non-enzymatic reaction, and over a period of 2 to 3 months, it accumulates glucose, and it's kind of like your average glucose level over 2 to 3 months that gets bound up to the hemoglobin. And usually it's less than 5.7% in its value for normals. For people who are at risk for prediabetes, it is above that, up to 6.5%. And then patients who have frank diabetes have elevated hemoglobin A1C of 6.5% and higher. Now, there are two other kinds of typical blood tests that are done to screen for prediabetes and diabetes. Both of them require fasting, typically fasting overnight for at least 8 hours, and most people prefer 10 to 12 hours of fasting. And under those circumstances, normal people have a fasting blood glucose, or fasting plasma glucose, in this case, that is less than 100 milligrams per deciliter. For pre-diabetics, it's 100 to 126, and then for people who have definite diabetes, your fasting plasma glucose is greater than 126 milligrams per deciliter. Now, there is an oral glucose tolerance test that is a standard test that's given to patients. A 75-gram glucose load is swallowed, and then blood testing is repeated 2 hours after that, so you get a basal blood glucose before you drink this solution, and then 2 hours later. And if at 2 hours your blood glucose is less than 140 milligrams per deciliter, that's considered normal. Pre-diabetics are 140 to 200, and diabetics are over 200 at the 2 hour interval. Now, the good news is that as I said earlier, most of the myotonic dystrophy patients with their insulin resistance do not have diabetes or even significant prediabetes. But if you look at what you would recommend for an individual with insulin resistance that caused that, the usual standard regimen is for diet and exercise, and that would be coordinated with your regular primary care doctor. And if they were concerned, you might need to be seen by an endocrine specialist and nursing care to help you with diet, including a nutritionist. There are a number of oral medicines that are given to treat type 2 diabetes. Some of those stimulate the pancreas to release more insulin. Some of those medications make insulin more effective after it's released, particularly effective in its ability to stimulate muscle and fat. And then there's also medications that, along with those actions that I've just mentioned, primarily decrease the amount of glucose in the blood. If those oral treatments are not totally effective or ineffective, then you use insulin injections. The vast majority of patients who require lifelong insulin, however, have type 1 diabetes, which is not typically associated with insulin resistance, but it's associated with a lack of insulin because, as I mentioned earlier, the beta cell is damaged and it is not able to produce insulin in sufficient quantities. Now, the good news that I've said a couple of times already is that there really doesn't appear to be an increased risk of diabetes, that is type 2 diabetes, in patients with myotonic dystrophy. This is supported strongly by the information we got from a recent survey of the NIH National Registry of patients with myotonic dystrophy, in that 8% of the myotonic dystrophy patients reported having diabetes. And if you look at the frequency of diabetes in people in the United States, according to the Center for Disease Control, it's about 9.3%. So members of the registry reported a similar frequency of using anti-diabetic medications compared to normals. And in general, I think that's encouraging. However, we already know from what I said several slides ago that insulin resistance is very common in myotonic dystrophy. So if it doesn't cause type 2 diabetes, how does this insulin resistance manifest itself? Well, one of the primary ways that it occurs is it affects lipid metabolism, or put somewhat differently, cholesterol and fat metabolism. So it alters lipid, that's fat and triglycerides, and it shows up by high levels of triglycerides occurring when you do your routine blood test. That's a 12-hour overnight fast, and the doctor has a blood sample collected and a lipid profile is performed. Your triglycerides would be elevated, and then there's an elevation of so-called bad cholesterol, the low-density lipoprotein that carries cholesterol, and the good cholesterol is low. So you have high bad cholesterol, that's the LDL, and you have low good cholesterol, the high-density lipoprotein, and those are very common early features of insulin resistance. And I don't have slides showing this, but two of the earliest actions of insulin on target tissues like muscle and fat are that it influences the regulation of fat metabolism, and it influences the regulation of potassium, and it also influences the regulation that insulin has in stimulating protein synthesis that is directly linked to increasing your skeletal muscle mass. So that while it is true that there doesn't seem to be an increased frequency of type 2 diabetes based on glucose alterations, there's certainly a significant impact of the insulin resistance on your lipids, and to a lesser but probably important extent, both on protein synthesis and potassium regulation, which, if they're altered over many years, could be major contributors to the symptoms that occur in patients, such as muscle wasting and myotonia with stiffness. It's interesting to keep in mind that in myotonic dystrophy, both type 1 and type 2, there are very specific muscles that waste away. And research that's been done in the past shows that the muscles with the greatest wasting, this is particularly true in myotonic dystrophy type 1, have the greatest resistance to insulin. So that it's easy to think about the receptor alterations as being linked to the mutation being most manifest and the abnormal RNA accumulating to the greatest extent in some of these muscles that are the most wasted. And this is the kind of research that will continue into the future, and hopefully we'll be able to do a better job of handling the insulin resistance. Now, one of the ways of treating the alteration in lipid metabolism, fat and cholesterol, is the use of statins. And that would follow largely the symptom created by the insulin resistance. And so what this slide shows is that approximately 19% of patients with myotonic dystrophy, at least 19% of the myotonic dystrophy patients in our NIH National Registry, reported having a high cholesterol. And this is higher than the value reported by the general population in the United States, that being 11%, which is not a surprise in view of what I've just told you about insulin resistance. Now, statin medications are very effective in lowering cholesterol, the total cholesterol. They also are very effective in lowering the bad LDL cholesterol, and to some limited extent, they're effective in elevating the good cholesterol, the HDL cholesterol. And this slide happens to show a couple of helpful references that you may want to turn to emphasize the beneficial role of statin treatment. And we've done a study showing that a reasonable percentage of patients in our national registry are taking statins. I don't want to be too coy, but we'll report that in our IDMC-10 presentation in a couple of weeks or less, and we'll be happy to share that. I will tell you that the percentage is approaching 20% or a fifth or so of patients in the registry. So it's possible to take statins and have a muscle disease and do okay. However, there are a lot of concerns about how best to regulate statin treatment and cholesterol in myotonic dystrophy, and it sounds very much like the recommendations that we would make for a patient who has type 2 diabetes, and that is diet and exercise. And then most important is to go over the benefits and risks of using statin therapy, not just with your neuromuscular specialist, but with your cardiologist and your primary care doctor. And this means becoming very knowledgeable about the importance of trying to continue your exercise program while you're taking statins, because they seem to have a combined benefit when performed together. You need to discuss the different types of statins, medications that might aggravate and potentiate side effects in statins, and then what might be the best plan if, in fact, certain symptoms develop and you may need to change your dose of statin or change the medication. The general rule is to use the lowest dose of statin necessary to bring your cholesterol down. And this requires what I've just emphasized, working with your local doctor and working with the physical therapist to monitor any potential muscle side effects. Well, as I was saying, insulin resistance in myotonic dystrophy, more frequently than causing a major problem in glucose metabolism, it certainly can cause elevations following consumption of a high glucose load, like drinking a Coca-Cola or something. But usually there's not that much elevation in the baseline blood sugar, in contrast to patients who have both prediabetes and type 2 diabetes. But one of the abnormalities that does develop, as I've mentioned in the previous couple of slides, is altered lipid metabolism, because lipid metabolism is very sensitively regulated even by low levels of insulin, and it would appear that the defect in receptor function allows abnormal elevation of triglycerides and cholesterol, particularly the bad forms of cholesterol and the LDL forms. So how do we reverse that? What are the best treatments? Well, it's very similar to the proper treatment of diabetes. That is, trying to maintain proper body weight, or shifting, if you will, your BMI towards a greater amount of muscle. Losing as little as 7 or 10 pounds can help, but also diet and exercise and anything that will increase the blood supply to your muscle. I realize we're dealing with a muscle disease that, if anything, wastes away muscle, but very often exercise in the form of some type of aquatic therapy or supervised exercise is possible in many of our patients. Now, all of the use of statins, and there are many different types of statin drugs, need to be discussed not just by your primary care doctor, but with your cardiologist and neurologist. And you should be very willing to switch statins, to take statin holidays, to use it intermittently in hopes of getting the needed benefit in lowering your triglycerides or cholesterol if you're someone who has marked elevations. And one of the references that's on here is something you may want to read that talks about the role of exercise as well as how the statins work. I'd like to switch gears a little bit, although, as I was saying earlier, it turns out that if we know a little bit more about the alteration in growth hormone release that occurs in myotonic dystrophy, it may lead us towards thinking about another endocrine hormone that may be not functioning perfectly, that could, under ordinary circumstances, be helping to bypass the insulin resistance. And that's the reason I've included this in this presentation. Now, the hypothalamus is a part of the brain that controls the stimulation of the production of a number of other hormones from the pituitary gland. And one of the functions of the hypothalamus is to release growth hormone releasing hormone. And that hormone stimulates the release of growth hormone, which in turn leads to the production of some other hormones that I'll mention in just a moment. But you can just see by this little cartoon that there are a number of different hormones that result that influence a lot of whole body functions. Now, normally growth hormone causes the secretion of another growth factor called insulin-like growth factor, insulin-like growth factor number 1 from the liver. And that growth factor is very important in stimulating protein production in muscle. It also can act as a surrogate for insulin, although that's not its goal. It can encourage glucose uptake. And it turns out, however, that the production of IGF-1 by the liver depends on the release of growth hormone. And if growth hormone release is inadequate, then the stimulation of the liver to produce IGF-1 is low. So if growth hormone activity is low, IGF-1 activity, amount of IGF-1 is low. And that's important because IGF-1 is important in producing adequate muscle mass and in also ensuring proper bone structure. In fact, patients with myotonic dystrophy, and in myotonic dystrophy type 1, where it's been actually studied, there's low to low normal levels of growth hormone, and the corollary to that is that there's a low normal to decrease in IGF-1 levels, and that this may have a role contributing to muscle weakness and wasting. Because of that, we embarked on a treatment trial with a preparation called iPlex. iPlex is a combination of IGF-1 attached to a little protein called IGF binding protein 3, and there are about 6 of these binding proteins, but without going into the details, that binding protein is very important in carrying IGF-1 to different target tissues within the body. And we were hoping that by giving injections of this material to patients with myotonic dystrophy type 1, we might improve their function, because there had been previous studies using free IGF-1 in a relatively small number of patients with myotonic dystrophy type 1, where those patients had gotten better. Well, we gave this iPlex preparation to 15 subjects, increasing the doses every 8 weeks, and we thought there was an encouraging trend, both not only in increasing the amount of muscle, but in reducing some of the complaints about fatigue, and they had improved body posture, and a small number of patients, mainly women, had a remarkable improvement in some of the gastrointestinal complaints that they had. And we were optimistic. Unfortunately, our optimism was not supported by a bigger multi-center study that was led by the company Insmed that manufactured iPlex. We had 13 centers, a total of 69 patients, and their criterion for deciding whether the medication worked was a muscle function test, specifically the 6-minute walk test, the distance walk. And we're sort of stymied at this point. I would hold out to patients the hope that the company that has the data will release more of it, and that maybe in the future there'll be an opportunity to re-explore how this particular medicine might help some functions and give us a better understanding of how this particular hormone or growth factor works. Now, what about other hormonal endocrine disturbances that can occur in myotonic dystrophy that may complicate both insulin resistance and muscle stiffness and muscle wasting? Hypothyroidism is one of those problems. And it's not clear that hypothyroidism itself is caused by the mutation in myotonic dystrophy. However, if a person has hypothyroidism, they are subject to aggravation of the symptoms of hypothyroidism by the mutation in myotonic dystrophy and the fact that already there's insulin resistance. So if you think about the thyroid gland that sits here in the neck, and as you know, the parathyroid glands, there are 4 of them, are buried in the thyroid gland, but the thyroid gland itself is larger. It sits on both sides of the voice box, and it secretes hormones that regulate brain development and function, has a role in the eyes and heart and a number of metabolic functions. And as a lot of other glands, the thyroid gland is governed by the pituitary gland. And the pituitary gland is regulated by the hypothalamus, as we saw in the previous slide. Now, the thyroid gland manufactures 2 major hormones. One's called thyroxine, and the other one's triiodothyronine, or triiodothyroxine. And these are the hormones, for those of you who are hypothyroid, as you know, your doctor will be measuring typically the T4 and free T4. And then they'll also measure your TSH level, which is a clue about how your brain sees the circulating level of thyroid hormone and whether your brain is satisfied that the amount of thyroid hormone circulating in the blood is at the level it should be. If you have hypothyroidism and you wonder what it is that could be aggravated in myotonic dystrophy, particularly myotonic dystrophy type 1, but it's true for both type 1 and type 2. An underactive thyroid worsens the myotonic. You become stiffer, you become more insulin resistant, and your muscle strength declines. And the thing that is worrisome, although there's no carefully controlled prospective study, in some of our own personal experience and in a few case reports that we've published, the degree of muscle wasting that occurs during the time the patient has hypothyroidism that's not being treated, very often that's not fully corrected when you restore normal thyroid hormone levels. Now, it's not clear why hypothyroidism of this sort worsens myotonic dystrophy. It's an opportunity for us to explore further and to also clarify exactly how many patients with myotonic dystrophy type 1 and 2 actually do have hypothyroidism. But you can see the symptoms from hypothyroidism are not radically different from what you see in myotonic dystrophy: fatigue, constipation, cold intolerance, weight gain, dry skin, you lose your hair. And sometimes patients will be kind of lulled asleep thinking, well, gee, that's myotonic dystrophy. But it is imperative that you keep up with your checks to be sure thyroid is okay. So there's a treatment. There's a hormone replacement. Synthroid, for example, is taken orally once a day, and you may have to take it lifelong, but it's definitely worth it. What about testosterone? Earlier in my comments, I mentioned that the testis and atrophy of the testis was one of the first endocrine abnormalities noted in myotonic dystrophy type 1. And low testosterone certainly function of the disease. Myotonic dystrophy type 1 causes wasting and damage to the seminiferous tubules in the testis, and it influences testicular function. And it impacts testosterone and causes alterations in the way shown in this slide. Normally, testosterone controls adult male physical characteristics, muscle mass, bone mass, sex drive, and sperm production. The dilemma in patients with myotonic dystrophy, both type 1 and 2, although it's been studied in much more detail in myotonic dystrophy type 1, is that not only do you get testicular atrophy, but also low testosterone levels, and often you have erectile dysfunction. And it's always a possibility, because myotonic dystrophy type 1 affects smooth muscle, that problems with erectile dysfunction are not totally due to just low testosterone. Some individuals, even though they have testicular atrophy, will have low normal free testosterone. And some of the erectile dysfunction will be smooth muscle. And those are individuals who will respond to compounds like Viagra. I'm not pushing Viagra, but that whole family of medications. So the treatment, besides that, would be testosterone. And you want to restore the level to mid-normal range. And there are a number of different preparations. It doesn't have to be an injection. There are gels, implants, and patches. Now, before I close, I did want to emphasize the challenges of pregnancy. And while it's not entirely clear that difficulties with pregnancy, particularly in myotonic dystrophy type 1, are primarily an endocrine disorder, certainly ovarian function is not totally normal in women with myotonic dystrophy, and it could be that the overall axis of brain regulation of ovarian function and crosstalk between these organs, meaning the ovaries and the brain, is not normal. I didn't mention it in the previous slide, but for example, Peter Harper many years ago did a number of studies in the men with testicular atrophy and showed quite clearly that the increased release by the brain of follicle stimulating hormone, which occurs in men, is virtually certainly related only to the end organ failure and the signal back from the end organ to the brain, look, you better stimulate the testis to make more testosterone, and it just isn't able to because of the pathological pathologic change in the testis. And while we don't fully understand what's responsible for that pathologic change, it seems that the brain response, at least in that regard, is appropriate for the degree of damage to the peripheral endocrine organ. And I think the same conclusion pertains to the ovary. And there are some studies that have been published over the years showing that there's some alterations in the release of brain hormones that stimulate the ovary. But there is a big opportunity to do additional studies in women. So with that long preamble, I just want to have you look at this slide showing the complications that occur in pregnancy, primarily in myotonic dystrophy type 1. I'll talk about briefly the opportunity in DM2 on the next slide. But during pregnancy, there's shortness of breath, and as you know, as the uterus gets larger and pushes up on the diaphragm, if the woman who is carrying the baby has some degree of diaphragmatic weakness, which is not uncommon, they can become quite short of breath, and that can lead to hypoxemia, particularly during sleep, and can be a potentially dangerous problem. There are also problems in failing to maintain their pregnancy in myotonic dystrophy, increased urinary tract infections, ectopic pregnancies, and polyhydramnios. It is true that women who have polyhydramnios sometimes will have an increased likelihood of congenital myotonic dystrophy in their infant, but that's not a certainty. Also in labor and delivery, you have in many women with myotonic dystrophy, although the number of studies are small, again, a lot of these studies have come from Great Britain. They show that there's a prolonged stage of first stage of labor. Some women are in labor for 24 hours or longer, and very often there's failed labor. Placenta previa is a common problem. Perinatal loss, it's not necessarily a stillborn, it's just when the baby is born, very often the baby has severe congenital myotonic dystrophy, and it sort of gives the impression that the baby is stillborn, but in fact the real problem is this severe form of congenital myotonic dystrophy. Postpartum hemorrhage is another problem, and then although this is not endocrine, you really need to do everything possible to avoid anesthesia risk and the avoidance of post-anesthesia apnea. Now, for myotonic dystrophy type 2, there really is limited information available, and we need to get more information about the complications that occur in pregnancy in those ladies. There are a small number of cases where it has been published that women get a greater worsening of their proximal weakness. They get more stiffness and more myotonia. And the good news in this very small case report was that those abnormalities went back to baseline following delivery of the baby. So if you are thinking about what the best approaches might be for managing pregnancy in patients with myotonic dystrophy, it is really important to consider detailed genetic consultation, family planning prior to pregnancy. That would include the obstetrician. It almost always will include either an obstetric genetic specialist and your regular primary care doctor and a pediatrician who could be prepared as necessary to assist with the delivery of if pregnancy is obtained. So the second bullet just emphasizes that there's a whole team of people who need to coordinate in order to get optimal, safe management of the patient, and there's an excellent review of anesthesia guidelines that you might want to consult that the MDF and others have worked on. As I emphasized before, during pregnancy, you really need to monitor the mother during the third trimester and before if she already has significant problems with weakness of forced vital capacity. There can be electrocardiographic abnormalities if the mother is hypoxemic or having trouble breathing, and all of this emphasizes the need to have the OB, pediatrician, and very often a cardiologist and a respiratory therapy person involved in management, depending on how much weakness the mother has and how much difficulty in the late stages of pregnancy. Now, there are a number of opportunities for research, and time today really doesn't allow us to go into all of them, but this slide, which is one of my sort of lead closing slides, just points out some of those opportunities. We really don't know enough about the different endocrine problems in myotonic dystrophy, both type 1 and type 2, and for sure in type 2, but I would say the same is true in type 1, because you can repeat some of the earlier studies with much better technology and probably get clearer answers. So what are some of the questions to explore? What are the approaches that we ought to use for exercise? Is there some insight that we can use that more modern exercise techniques and knowledge can allow us to apply? What about medications to improve our management of insulin resistance in addition to exercise? And then how do the obvious factors of aging, diet, stress, I haven't talked much about the adrenal gland or stress hormones, but how do other factors aggravate the endocrine issues that we know already exist in myotonic dystrophy? And are there differences in how we think about the endocrine issues between men and women besides the obvious? So these are all factors that really there's an opportunity for us to pull together, all of us who are care providers as well as patients and family members of patients. And then there's some just general principles that I think we need to follow, and the most important one, of course, is teamwork, and it's been emphasized by some of the points I was making in these closing slides, and that's the teamwork that we need to exercise to address some of these endocrine issues. So we need to discuss these issues with our local doctors, local care providers, family and researchers, and that's just first step. And then the next might be to make optimal use of some of the registries and other studies that are underway so that you can talk to the people, either talk to other patients or talk to investigators about the concerns and the kind of care that is being used to treat various endocrine alterations. And one of the things we're hoping that we can do is by developing a strong partnership between the NIH-sponsored National Registry based here at the University of Rochester and the Myotonic Dystrophy Foundation Family Registry, is that we can utilize this combination of a large number of interested patients with myotonic dystrophy to explore pertinent questions that will lead to some new way of understanding better management of patient complaints, and in this instance, in regards to endocrine issues. So there are a lot of opportunities out there, and maybe this is a good time to raise some questions and to discuss what some of the concerns are that those of you have.
Great. Thank you, Dr. Moxley. The first question I have, is there a recommended range for potassium intake for people with DM1 and DM2?
Well, you know, I don't think that's something that we've got good data on. I mean, I can tell you what you probably already know, that most normal people take in about 80 milliequivalents of potassium a day to, you know, that's the usual amount of potassium that's required, assuming normal absorption and normal excretion. And a lot depends on whether or not the individual has got some problems either with gastrointestinal function or with renal function that might cause them to lose potassium. It's true that a lot of us, as we get older, just arbitrarily choose diets that don't have food items that are particularly rich in potassium. And one of the practical reasons is if you look at a lot of food items, and I'm no authority on it, some of the items are a little pricey. So I think that's an opportunity for some of the registries as well as others who are nutritionists who are interested in working with our patients can educate all of us as care providers about better approaches. But right now, I can't give you a quote, a study that really has answered that interesting question.
Okay, the next question, are non-synthetic drugs like Armour Thyroid effective for hypothyroidism?
Yes.
Okay. Is insulin resistance the same as hypoglycemia?
No. Insulin resistance is really a condition where usually the glucose level is either higher than normal or usually normal. It's hypoglycemia that causes your glucose level to go low. Now, it turns out that there's less counter-regulatory function. I'll explain this gibberish in a minute, but there's less counter-regulatory function probably operating in many of our patients with myotonic dystrophy, which means that in a way they're even more protected against hypoglycemia. What am I talking about? It turns out that when you drink, like let's say 2 or 3 Cokes right in a row, you get a very big rise in your glucose level in the blood. And because in myotonic dystrophy, there's usually a very large outpouring of insulin in response to that glucose. And that insulin stays elevated. But because of the insulin resistance in the patients, even though the insulin level is still elevated, the glucose level remains elevated, and even over a period of 5 hours will stay elevated, and you don't get a rebound fall down in the glucose followed by, in quotes, lower glucose levels of hypoglycemia. It turns out that in the normal individual, what happens is that you'll take glucose in, insulin will be released, the body will sense where the glucose is, and if your glucose starts dropping too rapidly and looks like it's going to drop too far, i.e. create hypoglycemia, then your brain will signal, please release growth hormone. Growth hormone will come out and block some of the actions of insulin, and then there will be other hormones, certain so-called catecholamines that will come out and block the actions of insulin. These are things called counter-regulatory hormones that help combat people from getting hypoglycemic after they eat glucose. Obviously, you can get hypoglycemic over a long period of fasting, but usually you don't get symptoms with that, because when you fast for a long period of time, you start using fatty acids to help supply the fuels for your brain and other tissues. That's a long-winded answer, but it's an interesting question, and the good news is that the insulin resistance is different from hypoglycemia.
Okay, thank you. Is IPEX available now?
No, that's a problem. It's a long conversation, and maybe that's best handled offline. I get frustrated because I was hoping that there might be a way to make that available at least to some of our patients, because there clearly were some of our patients who had benefit from it, and I don't think it's going to be constructive for me to ventilate. It's just not available.
Okay. Would therapeutic use of growth hormone help?
We published an abstract on some of the work that we did several years ago, and unfortunately, growth hormone treatment for a period of approximately 4 months was effective in increasing protein as estimated by certain types of of imaging. We did total body potassium measurements, we did DEXA measurements, and it looked like there was a little bit of an increase in muscle. That was the good news. The bad news is that growth hormone, as you know from reading about acromegaly, aggravates the action of insulin. It actually causes insulin resistance itself. As I was saying earlier when we were talking about counter-regulatory effects, growth hormone is one of the ways that you can counter an excessive action of insulin. So it blocks insulin. And so what we did when we studied our patients, we thought, gee whiz, this is a frustrating combination. We're aggravating insulin resistance, and on the other hand, it looks like the muscle mass is going up. But the other negative information was the amount, the actual type and amount of muscle that we were stimulating with the growth hormone treatment seems to not be contractile protein. So the patients did not get stronger. But at the same time, they got more insulin resistant. And a lot of them had aches and pains in their wrists because, as you probably know, growth hormone, like you see in acromegaly, stimulates the growth of certain connective tissue. And for example, their wrists actually got bigger. And their facial structure changed a little bit. And this is just with a relatively short duration treatment with growth hormone. So this was another reason that we felt, gee whiz, we ought to be going to insulin like growth factor 1. In other words, maybe we don't really need to give growth hormone, and knowing all these side effects, let's just give IGF-1 and we'll be able to get benefits there from a hormone that we know growth hormone would stimulate, and it won't have the same side effects. So that's the short, I know it doesn't seem short, but that's sort of the short answer to the growth hormone question. Hormone usually acts on bone, and one of the actions is to stimulate actually an elevation in the level of calcium. And there are some protein symptoms that people can develop from that. And very often patients won't realize they've got hyperparathyroidism for some while. They'll feel tired or they'll feel a little goofy maybe because it depends on how high the calcium level is. And they'll have some aches and pains. The stomach won't feel good. But I mean, really protein complaints, and it can be very deceptive. Now, there are some much more uncommon causes for something that looks like hyperparathyroidism but isn't. But I think that what people need to do, once they've fallen into the category that the doctor's sitting there saying, gee, I don't know what's going on, then you need to have, hormonal tests carried out by your internist or very often by the endocrine specialist to measure and see how much parathyroid hormone is being manufactured, whether your vitamin D levels are normal, and figuring out whether your calcium levels are elevated and your overall body clearance of calcium and other electrolytes. It's very important in that setting also to be sure your vitamin D levels are okay. I don't know if that's your question. It's an important question. Does that answer your question, Leslie, or not really?
Are you suggesting that it's my question?
I'll change my response. The person who was asking that question, what do you think about my answer?
I don't know. We'll see. But it is listed in one of the recent journal articles about endocrine issues as one of the common endocrine problems for people with DM1.
Well, I don't know if I wrote that, but if I did, I'm not sure that's true. It's certainly something to think about, but if you go back and sort of review the PubMed literature and what Peter Harper has pointed out, there are isolated cases, and he raised the possibility that there might be a connection between hyperparathyroidism and myotonic dystrophy. I mean, the Japanese raised the question that pseudo-hypoparathyroidism might be connected with myotonic dystrophy. That's where there's a problem with tissue responsiveness to normal levels of parathyroid hormone.
Okay, so here's a question, totally different. It's a
Okay.
parent with a 23-year-old daughter who was just recently diagnosed with DM2. As a child, she saw an endocrinologist because she could not gain weight and stayed the same height and weight for 3 years. Eventually, she was discharged and she had a growth spurt. Now, as an adult, she cannot gain weight and has a very thin frame. Is there a relationship known in children and young adults having difficulty gaining weight who have DM2?
Well, that's a good question. I really don't know the answer to that. I'll answer it differently. In my experience, and I'm not sure that it really reflects what is truly known, I have not seen a case like that. But the fact that this person is concerned about growth regulation in the setting of DM2 makes me very interested in trying to get help from patients and different care providers. I mean, that's certainly a question that we could put to the registry populations, both the MDF registry and the NIH registry here in Rochester. And then maybe our colleagues in other countries would be comfortable asking their patients about this, because I frankly do not know about that particular series of problems and complaints. If it were my patient, I would probably be doing an independent workup of what might be going on to regulate, to not regulate growth appropriately in that individual.
Well, I can certainly send you a list of these questions if you want to share them with others. So for a final question, and this probably is one you won't care to address, what foods or nutrients have been found to be beneficial for people with DM1 and or DM2?
Yeah, you're right. That's not something. It's not that it's not something that's of interest to me. It's just I don't know the answer. And I think that beneath that question is a very fundamental assumption that we need to clarify. And I don't think that's been clarified. What is that assumption? That assumption is that if you eat a certain kind of pattern and you have myotonic dystrophy, let's say type 1 or type 2, that there will be, in quotes, normal assimilation, normal uptake of that food item, and that on top of that, the food item or food items will be disposed of in the proper way. And although I didn't take the time to go over it in this presentation because I wasn't sure that it was really endocrine, as you know, there are a lot of peptides, endocrine factors that are released by the intestine, and not just the ones that are active in regulating the pancreas, but ones that go and influence the brain. And I don't think this has been studied at all in any kind of depth in myotonic dystrophy type 1 and 2. And so on another occasion, when you invite someone to talk about on a webinar about the GI tract, maybe we could persuade one of our colleagues in Scandinavia who's got an interest, or someone else, to talk about the intestine and to talk about